use the focus gall, and welcome to the clinical applications video in the focus gallbladder exam series. So let's look at how we can use the focus gallbladder ultrasound. Let's take a look first if you have a normal gallbladder exam. Remember, we're not including evaluation of the intra or extrahepatic ducts. So if you've got somebody who has a normal gallbladder exam, this means the absence of gallstones, wall thickening, pericholecystic fluid, and the absence of a sonographic Murphy sign. This essentially rules out the diagnosis of acute biliary disease. In these patients, you should be looking for alternative causes for their abdominal pain. Defined as reproducible point tenderness directly over the gallbladder with transducer pressure, the sonographic Murphy sign is 87% specific for the diagnosis of acute cholecystitis. The presence of gallstones in combination with a positive sonographic Murphy sign has a 92% positive predictive value for the diagnosis of acute cholecystitis. A sonographic Murphy sign may be absent in patients with denervated gallbladders, such as in gangrenous cholecystitis. The sign may also be absent in patients who have received narcotic analgesia, but in my personal experience, if they're alert enough to follow commands, you're not going to obliterate their potential to have a sonographic Murphy sign just because you gave them narcotic analgesia. So I would not hold narcotics in these patients pending the gallbladder ultrasound. The sign may also be absent in diabetics, patients with gallbladder rupture or choledocholithiasis may also have a diminished or absent sonographic Murphy sign. But this is something that you want to do on every patient that you scan. You want to be able to assess them for the presence or absence of localized tenderness. How about the patient with a positive gallbladder exam? The two most important sonographic diagnostic criteria for the diagnosis of acute cholecystitis are the presence of gallstones and a positive sonographic Murphy sign. In combination, the positive predictive value is 92%. Since cholecystitis is an obstructive process, the gallbladder will also be typically distended. However, the absence of distension does not exclude the diagnosis. Thickening of the gallbladder wall and the presence of pericholecystic fluid are nonspecific findings. However, the presence of pericholecystic fluid of a biliary etiology would imply a more advanced case of cholecystitis. Some referred to the presence of wall thickening and pericholecystic fluid as secondary findings. Up to 18% of patients with symptomatic cholelithiasis will also have associated common bile duct stones. So remember, if all you're looking at is the gallbladder, you have not addressed in any way the presence or absence of choledocholithiasis. So therefore, operative intervention should not be planned until the CBD is evaluated. If you're able to adequately evaluate the CBD, then you've done a more comprehensive study. However, if all you're able to do is the focused gallbladder portion of the exam, somebody else needs to do the common bile duct evaluation prior to operative intervention. Because remember, somebody who's got choledocholithiasis should have an ERCP for stone removal first prior to their cholecystectomy. Acalculous cholecystitis accounts for up to 5 to 14% of cases of acute cholecystitis, and it is seen commonly in critically ill patients. The mortality rate is high if the diagnosis is delayed. Diagnosis is going to be made by the presence of gallbladder distension, the presence of infraluminal debris, and a positive sonographic Murphy sign. This was an elderly patient who had right upper quadrant tenderness and a fever. He had a sonographic Murphy sign, a dilated gallbladder with internal sludge and wall thickening, but no definitive stones. He subsequently underwent cholecystectomy and was found to have acalculous cholecystitis. Complicated cholecystitis. Gangrenous cholecystitis, emphysematous cholecystitis, and perforation of the gallbladder will occur in up to 20% of patients who have acute cholecystitis. The mortality rate is going to be increased if the diagnosis is delayed. And usually these people have more advanced cases because of a more difficult history and physical. It may be a patient who is in a chronic comatose state, an elderly patient with an unreliable physical exam. These are all patients who are at risk for having more advanced findings of cholecystitis due to delay. Here was a patient that had emphysematous cholecystitis. Note the presence in the non-dependent portions of echogenic foci with long shadowing posteriorly that has a quote-unquote dirty appearance. This was due to the presence of air. Gallbladder polyps. The current surgical literature recommends excision of polyps greater than a centimeter in size in patients older than 50 years of age, or any polyp that is clearly growing, even if it's less than 1 centimeter in size. Some people would recommend decreasing the cutoff number from 1 centimeter down to 6 millimeters, but it's important to recognize gallbladder polyps and make sure that people get referral and follow-up for these. This concludes the gallbladder clinical applications video.